It is now my great pleasure to welcome Dr. Hubertus Himmerich. He is a reader and consultant psychiatrist in eating disorders, and is going to talk to us about new drug therapies. Thank you.
Yeah, dear colleagues, ladies and gentlemen, it's a great pleasure for me to be here and talk about new drug therapies. Thanks to Janet Treasure, I had the opportunity to lead an international task force with members of all 5 continents to develop the update of the pharmacological treatment for eating disorders. And what we recommended in this new guidelines was for bulimia nervosa, fluoxetine and topiramate. However, topiramate can lead to cognitive problems and memory problems, and it is contraindicated in female patients of childbearing age. And unfortunately, most of our patients with bulimia nervosa are female patients of childbearing age. So this is a problem for topiramate. In bulimia, in binge eating disorder, the new guidelines recommend topiramate and lisdexamfetamine. Lisdexamfetamine is a stimulant, and there is overwhelming evidence for its efficacy in binge eating disorder. However, it is not yet approved for the treatment of binge eating disorder in the United Kingdom. Now, what about anorexia nervosa? Unfortunately, our task force could not give full recommendation to any medication for the use in anorexia nervosa as an add-on to psychotherapy. And the best medication was olanzapine. However, the acceptance and adherence rate is quite low for olanzapine, and that has also been a problem in a study that we are currently conducting, where we didn't manage to recruit as many patients as needed to proceed to a randomized controlled trial. However, there is hope, and the hope has been summarized by Janet and my previous PhD student, Joe Keeler, in the article you can see on the right-hand side. Please make sure you download both articles for free. No subscription, no advertisement, just download it for free. Okay, so how can medication be an add-on treatment, add-on to psychotherapy in anorexia nervosa? And I'll talk you through the evidence that Joe had nicely summarized. On a behavioral level, we have the reduced food intake and some anorexia-related activities. For example, physical exercise. And the self-starvation leads to inflammation. For example, Ulrikes and my previous PhD student, Bethan, has done a meta-analysis of interleukin-6 and TNF-alpha levels in cross-sectional studies, and we could see that both inflammatory cytokines were elevated in anorexia nervosa. On the other hand, the growth factors like BDNF and IGF-1, they are downregulated, and this is really bad for synaptic growth or neurogenesis. And this combination of inflammation and reduced neuroplasticity leads to increased damage in the neurons, and therefore damage markers like neurofilament L, tau protein, and GFAP, they are increased, right? So this is a damage to the brain, as indicated with this brain and the hammer. And as I said, neuroplasticity is decreased, the brain matter is reduced, the connectivity is reduced, which means that different areas of the brain cannot communicate with each other. And therefore, it leads to memory problems, cognitive rigidity, anxiety, and depression. And ladies and gentlemen, if a patient doesn't have the memory to remember what is said in the psychotherapeutic session, if they are rigid, if they cannot see the world and themselves from a different perspective. And they are anxious and depressed. They don't have the power to fight the anorexia. It's very hard for the psychotherapist to unfold their therapeutic potential. Right? This is indicated with the 3 question marks here. However, we have hope for medication that can help with food intake or with overexercise, and we have medication that might help with neuroplasticity. Let's start with a medication that can help to normalize the energy balance. I already mentioned olanzapine. Olanzapine is an antihistaminergic agent, and therefore it can increase appetite and food intake. However, patients have to agree to it. Our experience is they look up in the internet, see olanzapine leads to weight gain, and they don't want it, right? Then we have dronabinol, which is a cannabis-based medication. Like this is a cannabis-based Thai. It stimulates the cannabinoid receptors and therefore increases hunger. There are very good experiences in people with AIDS cachexia or cancer cachexia that dronabinol helps them to increase their body weight. And then we have a completely new medication, mitrolaptin, which is a leptin analog. And leptin is produced in the fat cells. And if we have enough fat cells, leptin is produced, and that signals to our brain we don't have to run and to hunt for food. And the same mechanism might be the case if you inject mitrolaptin, that people can better manage the urge to exercise. So these are the medications helping to normalize the energy balance. Then we also have 2 potentially new medications to help with the cognitive rigidity. One is psilocybin, the other one is ketamine. Psilocybin is produced by mushrooms, so-called magic mushrooms. And psilocybin can lead to euphoria, changes in consciousness, time distortion, perceptual alterations, and spiritual experiences. I see Nikki Kern, who is a psilocybin-assisted therapist, and she might be able to comment on that. However, as a PI, I am not supposed to know these things. Yeah, I'm fully blinded in this trial. Okay, there has been a meta-analysis for psilocybin's effectiveness in reducing anxiety and depressive symptoms. It improves the serotonergic transmission, the neuroplasticity, and it has been shown that it increases the production of growth factors in the brain. And there has already been 1 open-label feasibility study published in Nature Medicine this year, and this was a study in 10 adults with anorexia nervosa. This is a phase 2 randomized fixed-dose double-blind study that we are currently conducting. It's a multi-center study, and up to 60 participants with anorexia nervosa will be recruited. They'll be randomized with a 2-to-1 ratio to either 25 milligram psilocybin or 1 milligram psilocybin. The 1 milligram is the placebo condition, even though some people take it as microdosing. And the primary objective is to assess the efficacy of psilocybin with psychological support on improving anorexia nervosa symptoms. And secondary objectives are the improvement of OCD symptoms and weight gain. And of course, we also have safety objectives, which means we would like to assess safety and tolerability of psilocybin. The funder is Compass Pathway. The other medication that we are going to test is ketamine. This is an NMDA receptor antagonist. However, in sub-anesthetic doses, it increases the glutamate transmission. It is a rapid antidepressant in people with depression. Oh, I have only 1 minute left. Okay, I have to reorganize everything. So ketamine can directly stimulate serotonin receptors, and it can help directly with depression. This is completely different to other antidepressants where you need serotonin, and people with anorexia, they cannot build serotonin because they are lacking the tryptophan. This will be a double-blinded, randomized, controlled feasibility trial, and we have recently received the funding in principle email from the MRC. These two medications will help with psychotherapies, particularly identity-based interventions like mantra, exposure-based interventions, like, for example, the virtual kitchen that Valentina presented, or with cognitive remediation therapy. So in summary, how can the new medications help as an add-on in our treatment for anorexia nervosa? First of all, regardless of what we do, people need to have sufficient nutrition. Some patients manage solid food, others, for example, patients on our inpatient ward, they might need liquid food or NG tube feeding. Then we have medications that can help to stimulate appetite, like olanzapine and dronabinol, or a medication like metforeptin that helps with the overexercise. Potentially in the future, we have medication that will stimulate neuroplasticity, help with anxiety and depression, enable patients to see the future, to have hope, and to have the strength to fight the anorexia. And these medications will be psilocybin and ketamine. It will improve the effectiveness of our psychotherapies, and then the psychotherapies in turn will help patients to overcome their fear of food, and this will be a nice treatment cycle for our patients. Thank you very much for your attention. I have to thank a lot of colleagues in King's College London, South London and Maudsley and Imperial College, the WFSBP Task Force Eating Disorders, and of course the funders, the NIHR, Compass, and the MRC as future funder. And I'm happy to take any questions from you. Thank you very much.
Thank you for your talking. It was really nice.
It's a question on latency of measurements, because before I was in the research at Imperial, I looked into doing a PhD into fasting and the effects on the brain and media and all that sort of stuff. And it very much varied according to when you took the measurements post-fast. And I'm wondering, what's the latency that when you're measuring into like IGF factor 1, how long do you leave it after the fast? Because a bit like a muscles, I read some papers that you damage your muscle exercising it, and then in the repair, it gets better. There was some evidence in mice particularly that this is happening in fasting. And what relationship to ketone bodies might be.
Yeah, I mean, this is an excellent question because there are different dynamics. If you take ketamine, then you will have the antidepressant effect immediately. But this antidepressant effect will vanish. We know from our cytokine studies that it'll take a few months until interleukin-6 comes down, and I expect this is the dynamics in BDNF as well. As with everything in life, if you want to achieve something, you need the habits, you need to do something daily or weekly in order to have the improvements. And if it comes to brain structure and connectivity, patients might unfortunately not really achieve full recovery, but almost full recovery. There's a nice study by Kaufmann and colleagues about connectivity. It can improve significantly, but it might not go back to full connectivity. However, from this psychedelic trip, so the psychedelic trip is an overstimulation of connectivity. So you might get a few experiences that you might never get as a normal person without taking magic mushrooms or without psilocybin. So maybe you can draw on that and counterbalance and use these experiences, talk them through with a psychotherapist, which things. I have a lot of hope that an almost normal life is possible when you use the drugs plus the psychotherapy. I think the combination is important, and it might take a few months for the physical symptoms to recover.
Concurrent antidepressants as well, are you measuring that? So SSRIs.
SSRIs, yeah. Thank you so much. This is an important message. SSRIs don't work in patients who are starved. They don't have tryptophan, they cannot make serotonin, and SSRI cannot work. Once patients have weight recovered, they are useful antidepressants and they can be used afterwards. But I can see so often that fluoxetine is prescribed for patients, and as a consultant, I have to say sometimes myself, I continue to prescribe them, but it is nonsense. They don't help in people at very low body weight. Yeah, it's just to please the psychiatrist and the patient.
Because we don't. Yeah, sorry, we don't have much time. We need to call the next talk.
Yeah. Okay, people can write to me if they have further questions.